Good afternoon, everyone. If you could kindly take your seats, we'd like to get the session started. I'd like to introduce you to my fellow moderator, Dr. Caroline Tilliquette, who heralds from Lyon, France, and I'm Fiona Costello from Calgary, Alberta, Canada. And what we're going to present over the next hour and a half are state-of-the-art approaches to common neuro-ophthalmic problems. So without further ado, I'd like to start with our first speaker, Dr. Nicholas Volpe, who comes to us from Chicago, the Windy City in the United States. Nick.
Yes, another great city with a beach. I'm not going to confuse it with Nice, but greetings from Chicago. So we're going to, over the next 15 minutes, talk about patients who develop exophthalmos or proptosis as their initial presentation. And I think I could stop here and just tell you that most patients with proptosis have an identifiable cause that you could recognize based on exam findings, and every patient after imaging should have an explanation for true acquired proptosis as opposed to just mild asymmetry. These are disclosures, none of them are relevant to this talk. So we'll start with a case of a patient who presents with double vision, a very common accompaniment to proptosis. He's an older patient with 2 or 3 months history. He isolates double vision when he looks to the right. It doesn't hurt, and some redness. He has a history of atrial fibrillation and history of prostate cancer. Not relevant in this case, but anybody who has a history of cancer and proptosis deserves an imaging study. A previous smoker, again, another risk factor for cancer, and medications as you see. He's on a blood thinner, which would bring in the possibility of a spontaneous hemorrhage, none of which were the case here. He had recognized that his eye was a bit red. He did not have stigmata of thyroid disease, and as you can see, just a couple of millimeters of proptosis with an concomitant esotropia, any acquired strabismus that has qualities different in one position than another position, i.e. it changes in this case with abduction. There must be an associated explanation for that, either a nerve, muscle, or space-occupying process. We noted that the injection was a little bit more prominent medially, and his forced ductions, at least in the office, were difficult to judge. So the redness made me think of fistula, dural fistulas, particularly in people with prominent red eyes is an important cause of proptosis. Redness also accompanies thyroid disease. This would be a perfect fit for thyroid disease based on the presence of redness with proptosis. His history of prostate cancer brings all these metastatic disease as a potential. Obviously, an idiopathic inflammatory condition would be potentially causing this. Sarcoid, we learned just a few minutes ago, the great mimicker by involving extraocular muscles, and truly unrelated. Just looks like he's got 2 or 3 millimeters, measures that proptosis, and we have something else going on. And as I said, the image always has the answer in proptosis patients. These particular T1 weighted coronal MRI scans, you can see has a very large, isolated large medial rectus muscle. You can see it smoothly enhancing in this fashion. And then there's a critical finding on the T1 weighted axial images here, where while the muscle is enlarged, it doesn't really push on the eye, it kind of hugs the eye or adapts the shape of the eye, so it's globe conforming, which is consistent with his ultimate diagnosis. In patients with isolated unilateral eye muscle enlargement, these are some of the conditions that we consider, but in general, many of these are going to affect more than one muscle. We've seen it with thyroid, obviously with myositis, lymphoma, metastatic tumors, and the list as you see it for an extraocular muscle enlargement. So here's some other examples: isolated carcinoid, multiple metastases from breast carcinoma, metastases from prostate. Here's that slightly different appearance where the muscle abuts the globe and indents it a bit, causing what would probably be choroidal folds on the fundus exam, isolated muscle enlargement from lymphoma in that case. So because it was isolated, readily available, we just elected to biopsy the swollen muscle. You can see the medial rectus muscle clearly very enlarged in this case, and it turned out to be a lymphoma presenting with isolated extraocular muscle enlargement, and he did very well with radiation. So I'm not sure, maybe some of the experts in this corner of the room will tell me what the difference between proptosis and exophthalmos is. I use the terms fairly interchangeably. Proptosis is easier to say and explain to patients, but they, in my world, mean about the same thing. Critical clinical history, what are the systemic illnesses? What are the other associated symptoms? I would dare to say, except for maybe fat expansion that can occur in isolated fashion and thyroid, it's almost always you can always tell why someone has proptosis with good orbital imaging. In those cases, we'll deal with both high stakes and low stakes condition and how to present to them. Again, much of this room does not need a review of this anatomy, but the key element for proptosis is the fact that we're dealing with a confined bony cavity that doesn't fit any more than it was meant to fit. So generally, when patients have proptosis, either something is taking up space in the orbital fat, something is enlarging an extraocular muscle, or something itself has directed itself to grow in the orbit and to make the eye push forward. Bleeding would be another final cause. Here are some of the things that I consider critical in evaluation of patients with proptosis. Again, setting would largely be recent trauma, known systemic illness, history of cancer. I think the tempo is probably one of the more important things that'll put you in things I got to worry about this week versus things I can figure out over the next couple of weeks. Generally, anything that's associated with a rapid onset of proptosis or a quicker onset of proptosis is going to have a more obvious and a higher stakes etiology. Obviously, patients who have vision change in association with proptosis, they're going to be very high stakes situations unless it's over a very long period of time. Double vision, obviously a very common accompaniment because of whatever is enlarging or taking up space in the orbit is impairing the eye movements of the eye and therefore causing misalignment. There's a very specific symptom that you all know well, but that of gaze-evoked amaurosis, patients who lose vision when they look off, usually to the side or up, abduction or elevation, generally because of transient impairment of blood flow to the optic nerve causing the vision loss. That's a calling card symptom of optic nerve sheath tumors. I've seen it with other tumors, but generally tumors around the optic nerve can be associated with gaze-evoked amaurosis. Eyelid changes, obviously very critical. There's two very important. We'll show examples of these. Eyelid changes that associate with proptosis. One, of course, lid retraction, typical of thyroid disease, and the other, the S, like the letter S, shaped deformity of the eyelid, which generally means there's a mass in the lacrimal fossa causing asymmetric ptosis of just the lateral portion of the upper eyelid. Pain, believe it or not, most patients with isolated proptosis, particularly from benign orbital lesions, don't have pain. I think it's a safe rule to assume that if someone has thyroid eye disease, you should not blame pain on thyroid eye disease. Maybe a bit of ocular discomfort or burning, but true pain would generally favor myositis or idiopathic inflammatory syndrome. Obviously, anybody who has anything neuro-ophthalmologic and has a history of cancer, we always try to connect those two and assume that the disease is a consequence of distant or paraneoplastic processes. Thyroid disease, again, easy to go from a patient who developed systemic hyperthyroidism, a month later got treated with radioactive iodine, and 3 weeks later started to develop proptosis. That connection is pretty clear to make, but I'd urge you to think about thyroid eye disease in completely asymptomatic patients with no history of systemic thyroid disease, as well as the more typical patient. The ordering of how patients develop their ocular manifestations of systemic thyroid disease doesn't always fit with a systemic presentation. So just because you don't have that history, you still have to look for that. And potentially the history of autoimmune disease, which may make inflammatory processes more common. So here's thyroid disease. Here's a patient with the S-shaped deformity. This is a better example of that. Here's a person, obviously, who spontaneously can get her upper lid behind her eyeball. Sulcus abnormality, so sometimes proptosis is actually not proptosis, but it's enophthalmos of the other eye. And there are two important conditions to think about with enophthalmos. One of the circumstances is sort of a spontaneous silent sinus syndrome, which is what this patient has. An exaggerated superior sulcus is a clue to that with impaired elevation. So this is actually an enophthalmic eye, not this a proptotic eye. And of course, the other is a sclerosing or scirrhous breast cancer. Other eyelid changes, these are malar festoons, which are typical of thyroid disease, as well as inflammation of the caruncle, eyelid retraction, lid lag when you look down, and of course, eyelid retraction. Remember, lid lag or a pseudo-lid lag can be a manifestation of a third nerve palsy, so don't go down the thyroid route without being sure this isn't third nerve palsy. Obviously, when it's more acute, this is a patient with myositis and idiopathic inflammatory inflammation. and this patient with a retrobulbar hemorrhage presenting. So those findings are important. Unlike the patient I presented, this patient with metastatic carcinoid tumor has flattening of the globe associated with her metastases to the lateral rectus. That would correlate potentially with choroidal folds. And remember, occasionally patients with posterior scleritis will have fundus findings, as in this case, seen with exudative retinal detachments. Everyone chooses different imaging based on their institution and what they have the most experience with. I like orbital echography and confirming the presence of thyroid disease. I think it'd be very helpful in characterizing the reflectivity and the size of eye muscles. So that's generally the only place, along with dilated supraophthalmic veins, where I'm going to depend on ultrasonography. The choice between CT and MRI scan, here again, it's your preference. I choose MRI scan just because it's more predictable, unless I'm worried about something related to the bones, previous fractures, and other changes. And you can go back and forth between these in terms of their availability and how they may service you in your pursuit of a diagnosis. Again, CT is better for bones in this patient with a hyperostotic meningioma. And then I like eye muscles as they're seen on MRI scan because of the changes that can be seen in contrast. Remember that the thyroid eye disease and thyroid eye muscle is usually unique in terms of its pattern, with relative sparing of the tendon. And what is most important for you to consider in evaluation of proptosis and the examination of thyroid eye disease patients is looking for evidence of orbital apex crowding, as can be seen here with the arrows on the optic nerve. And here's a more apical picture. And again, on these axial views, you can see how this posterior enlargement is really associated with compression of the optic nerve. This is the other example that I alluded to earlier, in which the thyroid eye disease is primarily involving the fat. So you can see, based on the position of the lateral rim of the orbit and where the globe is, that this patient has bilateral proptosis, but there isn't actually a lot of eye muscle enlargement. It's more a presentation involving the orbital fat. And here again, nice example of tendon sparing. Involvement of the lateral rectus or isolated muscles is a little bit less common, but occasionally encountered. Again, thyroid eye disease can be used to detect subtle changes and in particular characterize the unique high reflectivity of eye muscles in thyroid eye disease. Idiopathic inflammation of the orbit can look like anything. These are both examples here of myositis. Obviously, it doesn't look anything like the thyroid patient. Diffuse enlargement involves the fat as well. Any rapid onset process associated with pain and this type of imaging, we're thinking about an idiopathic inflammatory process, and we're going to make that diagnosis absent of any sinus disease to make us think of infection based on a diagnostic test with prednisone. Here we are summarizing some of the obvious differences between thyroid and idiopathic inflammation. Again, generally no pain, very painful. Most commonly bilateral for thyroid, almost always unilateral. So if you just start with unilateral, not painful, you can pretty quickly get through this differential diagnosis. And as you work your way down, you can see that there's varying differences, particularly the absence of eyelid retraction with idiopathic inflammation, as opposed to it being a very common symptom with thyroid eye disease. I mentioned in the patient I presented the unique presentation of proptosis with a red eye. You can see this red eye is a little bit different than the patient that we described because of the arterialization of vessels all the way up to the limbus. This patient also had extraocular muscle enlargement, which is a very common accompaniment, along with superior ophthalmic vein dilation in patients with low flow fistulas. Other example of lymphoma, here's the classic salmon patch, or here's involvement of the lacrimal gland, and again, the classic finding of the mass lesion sort of contouring to the back of the eye. Examples of secondary tumors, this is a metastatic esthesioneuroblastoma presenting with an optic neuropathy. Here's a patient with an isolated metastasis to the inferior rectus that sort of looks like she has lid retraction, as well as these findings, which again, when you look at the muscles carefully, it's a very isolated focal dilation of the muscle, which would be atypical of thyroid eye disease. And finally, adenoid cystic carcinoma, which is one of the more aggressive lacrimal tumors that can present to the orbit. In life, besides thyroid disease, you'll encounter two generally benign conditions that present with proptosis. One is the classic cavernous hemangioma. The other is fibrous dysplasia, which often presents in adolescence. And here, the CAT scan is diagnostic. patients with lymphangioma can have very varied MRI scans and presentations with secondary hemorrhages. Here is another patient with a lymphangioma that was imaged at 2 different points 3 years apart, and you can see in the second set of images the progression of new blood and the cause for the proptosis. So this entity is usually easily characterized based on a presentation in childhood, and hemorrhage often occurs after an upper respiratory tract infection. The distinction between these 2 entities is usually made fairly easily on a clinical level based on the insidious presentation with proptosis in middle-aged women, often with cavernous hemangiomas, and fairly typical isolated lesions of the orbit, as opposed to the somewhat nettlesome and difficult presentation that we have with lymphangiomas. Orbital cellulitis and mucoceles are a very important cause not to recognize. Not much overlap between this and the other causes of proptosis based on the presence of orbital swelling, fever, in this case sinus disease, and a mucocele. You should recognize this because of who it's happening to, often in children, and the sine qua non, for the most part, absent trauma, is going to be the simultaneous presence of sinus disease as the etiology. Retrobulbar hemorrhage, a true emergency if you identify it with proptosis because of the ease of treating this with canthotomy and cantholitis. So in conclusion, we approach these patients based on history and what the context is and what may have precipitated it. We look for systemic disease. We try to characterize any associated eyelid and conjunctival findings. We depend on imaging to give us a differential diagnosis, and we do the systemic workup as needed. Never want to miss cellulitis, hemorrhage, anytime vision loss is present, metastatic tumors, and high-flow fistula, and the answer almost always comes from putting the clinical course together with the imaging, and very rarely, but sometimes very effectively, through a biopsy. So keep these in context as you go through these patients, as you work through the differential diagnosis, and pretty simply, imaging is always the first step in evaluation of proptosis. Thank you very much.
Now, coming from London, England, is Dr. Gordon Plant. And Gordon will speak to us on headache.
Thank you very much, and thank you for the invitation. In the interest of time, I thought I wouldn't talk about sight and life-threatening headache, such as GCA and raised intracranial pressure, subarachnoid hemorrhage, and so on. The most important question for all of those instances is, have you ever had a headache like this before? And if the answer is no, then you're thinking of something along those lines. However, a lot of patients with other types of headache are seen in eye clinics, and particularly migraine. And why? Because many patients with migraine have visual symptoms, visual aura, excuse me, visual aura. Light sensitivity is almost universal in migraine, if not during the attacks. Even between the attacks, they can still have light sensitivity. Migraine is sometimes provoked by light, and the pain is sometimes centered on the eye. And then we're also going to talk about eye involvement in dysautonomic syndromes. Now, the word migraine actually is French, and the English term is megrim. But it was always much more fashionable in England to have a French disease than an English one, so it gradually got converted to migraine. And all of these terms, there's dozens of these around in every language, are all corruptions of Galen's term hemicrania, and that gives you a very important indication as to one of the main features of migraine is that the headache is unilateral. Not always, but very, very commonly unilateral. And with common migraine, it will change sides. So we have a throbbing quality, association with nausea, if not actual vomiting, a sensitivity to light, noise, and smells, exacerbation by movement, and a paroxysmal nature. Patients with migraine are perfectly well in between the attacks, and they often feel really well once the attack is over. But of course, all of those of you who have migraine know how severe the headaches themselves can be. And there is often an aura or prodrome. When my wife and I were medical students, we visited this town in Holland, and my wife, who has migraine, said to me, "Oh, this is why it's called a fortification spectrum. It looks exactly like this." I was skeptical. I did some research and discovered she was absolutely right. And she's been absolutely right about everything else ever since. And the term tychopsia, which some of you may have come across, was coined by the English physician Hubert Airy, who produced these wonderful drawings, which are often reproduced in textbooks. And I carry these around with me. I show these to patients because this is the most common type of aura. And tychopsia, as the Greek scholars amongst us will know, means wall vision, walls before the eye. So the same reference to the fortification. And we can think about the migraine aura now in terms of the pathophysiology because it is really more like epilepsy than anything else, but it happens very slowly. And it's based on an electrical disturbance in the brain known as spreading depression, which was first described by the Brazilian physiologist Leon. As we're in France, I thought I'd also show you the chevaux de frise, which Oliver Sacks thought meant frizzy hair in his textbook on migraine, but of course all of you French speakers will know that it refers to the Frisian horse. The Frisians apparently had no cavalry, so they invented this device to interfere with the enemy cavalry. So this is similar to the tychopsia, but the lines are more jumbled up, which gives it this type of appearance. So if a patient tells you that they have an aura preceding their headache, is it due to migraine or is it epilepsy or was it a TIA? Well, it's usually confined within the hemifield. Apart from tychopsia, we have a cracked glass or cracked mirror appearance, heat haze, sometimes described as heat haze, where they are not blind, they can see everything, but it's as if they're looking through a glass with water running down it. Or you can get a complete hemianopia with no visual symptoms. Vertigo, we now know, is a very common migraine aura, and also somatosensory. But what all of these have in common is a gradual onset and a duration, very important, the duration 10 to 20 minutes. Now, Nat Bloor, who was one of my teachers at Queen Square, he first highlighted the fact that many patients with migraine also have a prodrome of particularly yawning is very common, gastrointestinal upsets, basically a hypothalamic disturbance going on for many hours before the aura, which, as we've just said, is less than an hour, and then the headache. So you may also find your patients have a prodrome. I'm often asked who with a migraine aura needs a scan. Well, I've seen thousands of patients with migraine aura over the years, and my published series was, I think, about 16 cases who had an underlying structural lesion. So it can happen, but it's very, very rare. And one of the main features of these cases is that the aura will always start in the same place in the visual field, which is very unusual for typical migraine. It moves about. And here was a patient who had an occipital cavernoma, who had what was thought to be a typical migraine, but it always started in the same place in the visual field. And actually, these cases often respond very well to anticonvulsants, better than migraine ever did. So we have theories now about how the headache is generated in migraine, and your patients need to know that we are at last developing specific treatments. Up until now, most of the treatments for migraine were borrowed from the vascular theory of vasodilation and from the treatment of epilepsy. But at last, some more specific treatments are now becoming available. But there's another group of patients which have quite different types of headache, but which are also always unilateral. But these tend to be side-locked, unlike migraine. They will always occur on the same side. Always exceptions, of course, but that's the typical feature. And these are paroxysmal again, but very short-lasting, some only seconds and some many minutes. And as I was saying, we are looking for dysautonomic manifestations, which are often revealed in the eye clinic. We saw a case earlier on today where a partial Horner syndrome was due to one of these types of headache. They don't tend to have triggers, and unlike migraine, they are much more common in males. And the peak age range is also much older. Migraine, we'd say under 30, in these conditions, 30 to 50. So cluster headache is the one that's most familiar. So we have paroxysmal retroorbital pain. Lacrimation and nasal congestion are often the most common dysautonomic manifestations, but Horner's can also occur and may become permanent. The headache has a very different quality from migraine because the typical picture of the patient with migraine is they go to bed, they draw the curtains, they want no light, no sound, and they want to be absolutely stationary. This is a very different type of pain. It makes the patients pace up and down. They cannot keep still. And that's a very consistent feature. It's relieved by oxygen, and sometimes these patients have home oxygen as treatment for this, and it's probably more effective than many of the medication type treatments that we have. I've known angle closure glaucoma, intermittent angle closure glaucoma, be misdiagnosed as cluster headache. And it's called, the term cluster, of course, arises because these patients have headaches which tend to occur over a period of some weeks or days, and then they have long intervals without headache. But that doesn't have to happen, and there is a chronic form of this which curiously is more common in women, where they get daily attacks with no clustering. So what's causing cluster headache? I've given you some hints on how to diagnose it. There's some sort of central dysfunction going on, and it's been shown on functional imaging that there is hypothalamic activation ipsilateral to the headache. It's been very, very difficult to get patients with classical migraine into fMRI scanners. There's only a very few publications on this because it's so difficult to do this. However, with cluster headache, it was quite easy. You bring the patients into hospital, which is what Peter Goadsby did at Queen Square. He brought the patients into hospital when they were having a cluster and just sat them outside the scanner, and they went in whenever they were having an attack. And this is where this hypothalamic activation has been demonstrated, which of course fits well with the dysautonomic features. Now, cluster headache is best known and is commonest. The duration tends to be many minutes, but there's another group of patients which can also have eye pain and eye symptoms. SUNCT is the initialism for this condition. There you are, you have it. This, by definition, affects the eye. Again, it's much more common in men, and this lasts for seconds. For it to run into minutes is really, really unusual, and the attacks can be very, very frequent. Structural lesions have been reported, but they are rare. And most of these conditions in this group, not cluster headache, but in this group, we also have unilateral headache syndromes, can be diagnosed therapeutically by a response to indomethacin. And different patterns are emerging from the fMRI studies. Trigeminal neuralgia does not cause ocular pain, and in fact, the lower division, the mandibular division of the trigeminal nerve is more often affected. But nonetheless, patients with trigeminal neuralgia do turn up in eye clinics. The important thing to remember, I've seen so many things called trigeminal neuralgia that are not. It's called lancinating the pain, and this refers to a lancet, which was the it's like calling things in pathology spindle shape. No one knows what a spindle is anymore. And a lancet was used for bloodletting. And you just have to imagine yourself being jabbed in the face by one of these, And that's the kind of pain. These are lancet windows. So it refers to the shape of a lancet. And there are always triggers, cold wind, touching the face, brushing teeth, eating, etc. And this does respond to carbamazepine. We think most of these cases are symptomatic of neurovascular compression of the trigeminal nerve. But remember, if you have a trigeminal neuropathy, you will find signs of sensory dysfunction in trigeminal territory. And these patients can also have pain, and we call this neuropathic pain because it's associated with damage to the nerve. And it can occur after trauma, with tumors. We quite often see it after orbital surgery, where there's been damage to the supraorbital nerve, for example, or infraorbital nerve. But there is always something to find. You can find some sensory disturbance, which you never find with trigeminal neuralgia. And the pain does not have that lancinating quality. Lastly, there's an interesting condition which probably is one of the most common referrals I get with facial pain from ophthalmology, which is atypical facial pain. And that was named to distinguish it from trigeminal neuralgia. So although the pain is in the face, it's absolutely continuous, constant. The patients wake up with it, they go to bed with it. It's there constantly, often interferes with sleep. And it does not respond to painkillers, but it does respond to amitriptyline if used correctly. And there is an ocular form of this. I've seen many patients with eye pain, which has all of these features. And of course, they've been through all of the possible treatments that they can get from ophthalmology, but they need to be treated as one of these types of headache. So thank you very much. We have 1 minute. Would you like a question?
Yeah, absolutely. We're going to allow time for questions at the end as well.
Oh, okay.
But if anyone has a question, Gordon?
Burning.
Shlomo is chomping at the bit here, I think.
So the next topic will be about optic atrophy, and Shlomo Dotan will give this topic. And Shlomo is very engaged with SOE, and he organized all the neuro-ophthalmology sessions of this meeting, so we can thank him about that also.
Okay, today I'm going to take you on a very different trip, which is called optic atrophy. And basically, it's a misnomer because there is no atrophy here involved. And optic atrophy is not a diagnosis at all. As you can see, I have no financial interest being a neuro-ophthalmologist, but there is a very nice story with this slide. This is a young beggar in London with his cup and reading Marx Capital. You know, I have seen so many similarities with this young guy, so I put it into my disclosure statement. Okay, so I will start with an index case of a 50-year-old male whom I've seen lately and who was referred to me due to an incidental finding of bilateral optic atrophy on a routine eye exam. On examination, his uncorrected visual acuity in the right eye was fantastic, while in the left eye he was seeing only 0.4. His color vision, of course, in the right eye was perfect. It was not that perfect in the left eye. He had a left trace RAPD on the pupillary exam. And on the fundus, as you can see, at bilateral pale optic discs. And his OCT RNFL showed an average thickness of 49 in the right eye and 36 in the left microns. So it was an optic atrophy, of course. As always, we ask questions these patients, and on additional history, he told us that at the age of 13, he was hospitalized in the same hospital for headache, diplopia, and blurry vision. And on examination, he had bilateral optic disc edema, a normal brain CT, visual field loss, and opening pressure of lumbar puncture of 210 millimeters. Interesting. Do we know the reason for his optic atrophy? Not really. Could it be post-papilledema? Could it be labors? Could it be post-AION? Could it be post-optic neuritis? I don't know, because I haven't seen him back. But with this, I would like to open the session of my talk on optic atrophy. So as I told you, optic atrophy is a misnomer, and optic atrophy is not a diagnosis. Optic atrophy is actually a final common endpoint of many disease processes that can cause loss of some or most of the fibers of the optic nerve, or it can be a congenital condition. It generally manifests as a change in color and structure of the optic nerve in association of visual dysfunction. And you probably all know the manifestations, which are decreased visual acuity, decreased contrast sensitivity, depressed color vision, RAPD, whenever it's unilateral. Whenever it's bilateral, it can be no RAPD. Visual field defect or visual field defects, and it can be central, it can be peripheral. And of course, additional findings like proptosis, strabismus, headache, and skin changes. And I just want to remind you that optic disc atrophy develops in about 6 weeks, sometimes more, following an optic nerve lesion. And while being solitary, the optic atrophy is a fast localizing sign. Now, the usual list of etiologies of the optic neuropathies that can convert into optic atrophy is very well known to you, of course. And I will repeat it, although we had all day been dealing with them. It can be demyelinative, inflammatory, infectious. It can be traumatic. It could be ischemic, hereditary, GON or glaucoma. It can be compressive, and that's the most frightening reason that we generally meet. It can be neoplastic, it can be infiltrative, it can be due to increased intracranial pressure, and it can be, of course, toxic and nutritional. Now, you all know that the correct evaluation of the optic atrophy is very, very important for the diagnosis of the ocular systemic diseases. And we as ophthalmologists should be very, very careful in not writing optic atrophy, but seeking the real diagnosis. we are aware of multiple classifications and subdivisions of optic atrophy, and most of them, which you use in your daily practice, can guide you into the correct and final diagnosis. I will give you one or two of the classifications of the optic atrophy, starting with what's called primary, secondary, and other optic atrophies. In primary optic atrophy, we all know that there is no antecedent swelling of the optic disc. The lesion is generally between the retrolaminar optic nerve and the lateral geniculate system. This is how the optic atrophy in this primary optic atrophy group looks. The causes are various. You can have optic neuritis. You can have compressive reasons, the classical toxic, nutritional, and hereditary causes. You can have demyelinative causes, traumatic causes. And remember that the temporopellar of the optic nerve can be due to atrophy of papillomacular bundle, and also that band atrophy can be due to lesions of the optic tract. Now, secondary optic atrophy is when there is procedure by long-standing swelling of the optic nerve head in cases like atrophic papilledema, for instance. The disc generally is raised, has a very dirty, white grayish color. The margins are poorly delineated, and the lamina cribrosa is obscured. You can find pattern lines, and there is sheathing of arterioles, and this is how it generally looks. Also, we can see secondary optic atrophy in cases like NAION or non-arteritic anterior ischemic optic neuropathy, papillitis, or neuroretinitis. There is also consecutive optic atrophy, which is caused by a disease of the intraretina and its blood supply. The causes can be centroretinal artery occlusion, status post-PRP or RP, retinitis pigmentosa, retinochoroiditis or myopia. And of course, there is the famous glaucomatous optic atrophy, where you can find deep and wide cupping of the pale optic disc and disappearance of the nerve fiber layer. Very important is to divide the optic atrophies into the tempo of the presenting illness, and I'm going to give you some more examples, like laterality, like age. And let's start with the tempo of the presenting illness, where we have the acute onset, hours or days, in cases of optic neuritis, NAION or AAION, AAION being arteritic anterior ischemic optic neuropathy, traumatic optic neuropathy, and then you have the insidious onset in cases of toxic metabolic, nutritional, hereditary optic neuropathies. And in between, we can find the subacute onset in compressive optic neuropathies, inflammatory, and demyelinative neuropathies. Laterality means you can have unilateral optic atrophy or bilateral. Unilateral generally goes with optic neuritis, NAION, compressive causes, traumatic causes for optic atrophy. And in bilateral cases, I would put atypical optic neuritis or neuritis, AION, glaucoma, which is a bilateral disease, toxic nutritional and hereditary optic neuropathy. And we have the age. Accordingly, we'll see that children most probably will be with hereditary optic neuropathies or nutritional deficiencies, optic nerve glioma. Adolescents will show Leber's hereditary optic neuropathy, MS, NMO, neuromyelitis optica. Young adults will show optic atrophy in optic neuritis, traumatic optic neuropathy, meningiomas, and older patients in AION, NAION, central retinal artery occlusions, hypertensive retinopathy, diabetes, paraneoplastic syndromes, and of course gender, where males will show us LHON or Leber's, traumatic and toxic neuropathies, females more common in MS, meningioma, collagen vascular diseases, Sheehan syndrome, and of course, in overall, optic atrophy is more prevalent in African than white people. And we have the smaller diagnostic tips that will help us in working up these cases. We all know that optic neuritis is a self-limited disease, but may recur. Compressive optic neuropathy is progressive, and it doesn't improve. NAION does not improve, while AION can involve the fellow eye. And that's the main reason to treat as early as possible. And of course, toxic optic neuropathy can be partially reversible. Now, we've been talking and discussing hereditary optic atrophies, and I didn't want to miss the opportunity to repeat it. We have the Leber's disease, which is of course maternally inherited with point mutations in positions 11778, 14484, and 3460. We have the DOA, or ADOA as it's called in Europe. You know why they don't use DOA in Europe? Do you know? DOA is the abbreviation of dead on arrival. Oh. So we don't use it in Europe. We have in DOA two genes, OPA1 and OPA3, which encode inner mitochondrial membrane proteins, and three loci, which are currently known for DOA. And of course, we have the Wolfram syndrome, which includes diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, which is a disease inherited as an autosomal recessive trait, all ending in optic atrophy. I cannot finish a very short review of optic atrophy without mentioning this disease. So we're talking about Foster-Kennedy syndrome, which is olfactory groove meningioma, first described by Foster and then Kennedy in olfactory groove meningioma, which is optic atrophy actually, and anosmia with contralateral papilledema. Of course, by the way, this is the olfactory groove meningioma. This is a disease caused by a meningioma, which is, as you can see, coming to a dimension of a grapefruit. And you have also the pseudo-Foster Kennedy syndrome, where you have also in one side an old optic atrophy due to AION, and then on the other side a new AION episode, and it's called pseudo-Foster Kennedy. There's a take-home message, by the way, in this short review, and I took it from the classical article of Andy Lee from 2005, and he was referring to a very concise work on isolated optic atrophy, and he started his recommendation by saying that it should be ophthalmoscopically diagnosed according to the color, loss of vessels and nerve fibers, and the clinical exam, while taking the history, you can generally come to the diagnosis in cases of prior optic neuritis, NAION, toxic or nutritional optic neuropathies, and hereditary optic neuropathies, or cases of post-papilledema optic atrophy. But if after the complete neuroophthalmic history and examination, patient is still undiagnosed and has an isolated optic atrophy, you have to proceed to imaging. And of course, we're dealing with an MRI of head and orbit with fat suppression, or CT, wherever it's contraindicated. And by the way, in his review, there were 20% of cases where the isolated optic atrophy had compressive lesions behind them. So those 20% cases are good enough to demand us to send those patients to do an imaging. Sorry. Not yet. Screening blood evaluation are not recommended. So there's no reason actually to send those patients to a long, long list of blood tests, but to go straight to do the imaging of CT, MRI.
Thank you.
Thank you.